I was invited to talk about multisystem inflammatory syndrome in children, or otherwise known as MISC-C. Again, this is a condition that is thought to be rare following a COVID infection, but I will say that in the last 3 or so weeks, or 3 or 4 weeks, we have been seeing about half of our inpatient service right now is MISC-C kids. And, we are a tertiary care children's hospital in Chicago, so a little bit biased because we see children from all over the state and all over the city of Chicago. But that is a significantly higher number than what we were seeing in the summer, and probably reflects higher number of COVID cases in pediatric population in general in the U.S. at the moment. So the objectives of this study are of this presentation is to provide a quick update on the current knowledge of mechanisms of MISC-C, identify the symptoms that are associated with MISC-C, and then understand the management of patients with MISC-C. So the case definition for MISC-C, according to CDC, is given here. Essentially, it's any individual that is less than 21 years of age, presents with fever, and has lab evidence of inflammation and evidence of clinically severe illness that requires hospitalization, and has more than 2 systems involved, or organ systems involved, and they should have no other plausible diagnosis, and they should either be positive currently for the SARS-CoV-2 infection by RT-PCR, or they should have an antibody test that's positive, or an antigen test that is positive, or they should have known COVID-19 exposure within the 4 weeks prior to the onset of symptoms. So if you look at the antibody response in COVID-19 in mild disease versus severe disease, and that includes MISC-C, it looks a little bit different. So these graphs, the graph on the left-hand side is that in mild disease. And so what we think happens is that as a person gets infected, the viral load goes up. That induces an interferon response. It induces IL-6 response, chemokines, and altogether there's sort of this rapid viral clearance, and then the inflammation decreases. The person develops IgG antibody, and that's sort of the end of that COVID episode. However, in patients who have more severe COVID disease or go on to have MISC-C, what we think happens is that there's delayed viral clearance, and because of that, perhaps there is sort of this delayed, the interferon response is persistent for a longer time, IL-6 is higher for a longer time, and because of that, there's sort of this, much more inflammation in the body in general. So I will say there is very little that's known about MISC-C. It was only recognized several months after the pandemic started. And so this is, whatever I'm presenting today is based on the limited knowledge that we have right now. And so MISC-C has been linked, so temporally has been linked to SARS-CoV-2 and occurs as a late manifestation in response to the infection. And typically, if you look at the community rates of MISC-C, they peak about 3 to 6 weeks after the peak of the SARS-CoV-2 or COVID in that particular community. And again, that's because this is thought to be a delayed reaction to COVID itself. The majority of patients who present with this will have neutralizing antibodies to SARS-CoV-2, and their IgG titers tend to be higher than the IgM, indicating that this is sort of a late manifestation of the infection. Compared to patients that have acute COVID, patients with MISC-C tend to have a lower viral load. So if you look at the RT-PCR, they will have a higher a higher cycle threshold, meaning that it takes longer for the test to turn positive. And patients with MISC-C tend to be younger and less medically complex than patients with severe COVID-19. So a lot of patients that I've seen, they are otherwise completely healthy and then present with MISC-C. They can have enrichment of both IgG and IgA autoantibodies. So these are, again, antibodies that are directed towards a person's own peptides that are expressed in the endothelial, the cardiac, or GI tissue. And they can also have antibodies that are directed towards their own immune cells. So this is a study this actually is a very good review article that was recently published in JAMA Rheumatology, if anyone's interested. And I'm sorry, this is Nature Review of Rheumatology. So what they described was that it looks like over the course of MISC-C, the immune landscape changes. And so early on in the disease process, there are high serum levels of multiple cytokines, including IL-1, IL-6, IL-8, TNF-alpha. If you remember from med school, these are all the pro-inflammatory cytokines. And then there's also a higher number of activated neutrophils and monocytes that express this Fc gamma receptor. This receptor has a high affinity for IgG. So like as I mentioned previously, we think these patients have a high number of autoantibodies. So those high IgG levels activate the neutrophils, and then you have these activated neutrophils. And at the same time, there's decreasing circulating levels of your regular CD4, CD8 T cells and B cells. And then as MISC-C resolves, there's then that innate immune system and the adaptive immune system become more normal, and there is a higher abundance of these regulatory T cells. And again, regulatory T cells are those that dampen down the infection or the inflammation, so that makes sense. This study was only based on 25 patients. So again, very sparse data, but this is what we sort of know of right now. So again, emerging data show that MISC-C is characterized by these classic findings of inflammation. Fever is one of the main feature of MISC-C. And then multi-organ dysfunction includes skin, mucous membranes, heart, but it can also include, GI, respiratory, neurologic symptoms. Again, we think that MISC-C is a sort of a continuation, it's sort of a spectrum of symptoms, but we don't really have a validated diagnostic criteria in order to diagnose MISC-C. So still, patients are showing up to our ER, despite the fact that we've now seen close to probably 60 patients in my institution alone over the last couple of months. It's still sort of confusing. What is MISC-C? What is sepsis? What is acute COVID? What is sort of severe COVID? So just a lot of sort of discussions happening every time these patients show up. So this figure I thought was a nice one. It sort of summarizes the main features of MISC-C. So again, fever is one of the most common features, and other common features include cardiac dysfunction and coronary artery aneurysm. You can have vasculitis and endothelial dysfunction. Skin manifestations can occur. And then, as I said, both the innate and adaptive immune system there's dysfunction of both arms of the immune system in MISC-C. So if you look at the organ systems that are involved, most commonly the cardiovascular system is involved in most of these patients. This is again a sort of a review of a number of different studies. This review included 10 different studies and looked at the patient characteristics that were reported in those studies. The GI manifestations are fairly frequent in these patients, and a lot more than in acute COVID. And then patients can also have skin manifestations, and a few of them will have respiratory symptoms and neurologic and musculoskeletal symptoms as well. And this is a recent study that was published in JAMA Dermatology that looked at the skin manifestation of patients with MISC-C. So they can have conjunctivitis, some skin cheek erythema, they can have a strawberry tongue, erythema of the hands, periorbital edema and erythema. And you'll notice that a lot of these skin manifestations especially are those that look like Kawasaki's disease as well. And then they can also have different forms of rash on the trunk, on the legs, the sort of particular rashes that we tend to see with Kawasaki's. And I'll also see that there was I should have mentioned before, but there's when MISC-C was first reported, there was a lot of confusion about what is Kawasaki's and what is MISC-C. And so when a lot of these review articles, when they are trying to analyze all of that data together, they've tried to separate out Kawasaki's disease versus what we now think is more is a distinct syndrome that is different, that is related to COVID and separate from Kawasaki's disease. But as you can see, a lot of the skin manifestations, there's certainly an overlap between those two syndromes. This is a really nice systematic review that is available as open access. So if anyone's interested, do download it and read it in more detail. But this was based on 39 observational studies, and it basically showed that among all the children that had MISC-C, 71% of them were admitted to the intensive care. So clearly, these children get very sick, and there were also 11 deaths that were reported. So that's about 1.7% death rate. The average length of hospital stay altogether was about 8 days. So if you look at the patient characteristics, a lot of these patients had comorbidities, but about half of them were overweight or obese, which is fairly interesting. And then, not surprisingly, most of them were positive had some evidence of SARS-CoV-2, either the PCR being positive or the antibody being positive. And on average, they had symptoms for about 5 days before they're presented to the hospital. And then when we look at the lab measures, most of these patients had pretty profound lymphopenia. So their lymphocyte count was very low. They tended to have low albumin, relatively high creatinine, and then sort of borderline high ALT and AST as well. If you look at their inflammatory markers, they had very significant elevation of both CRP and ferritin, and then some of the other inflammatory markers that we tend to get in the US sometimes, like IL-6, were very elevated as well. As I mentioned before, the patients with MISC-C, we think, develop these autoantibodies to endothelial tissue, and they are sort of in this hypercoagulable state. So not surprisingly, a lot of these patients had high D-dimers and high fibrinogen levels. And then a lot of patients also have cardiac manifestations. And so that elevation of their troponins and the BNPs are in about the thousands range. Most of these patients that had presented with MISC-C had an echo that was performed. About 50% of them had abnormal echo. About 30% had an abnormal EKG. A significant proportion of them had an ejection fraction between 30 to 55%, and 5% had very low ejection fraction. They also, about 8% had cardiac coronary artery aneurysm, and about 20% of them had pericardial effusion or pericarditis as well. So the biggest question, as I mentioned, it's always, comes up: is this COVID-19? Is this acute COVID? Is this severe COVID? Or is this MISC-C? So again, how do you differentiate between the two? I think this review article did a very good job in trying to understand the differences between the two. And so patients with MISC-C tended to have higher, were more likely to have comorbidities compared to those with COVID-19. So I will say, anecdotally, in my experience, in the patients that we have seen at Lori, those that have more severe COVID tend to actually have more comorbidities than those that present with MISC-C. So again, this is a very new disorder, and we have very few numbers. So take this with a grain of salt. If you look at the signs and symptoms, by definition, all the patients with MISC-C have to have symptoms. So there's no such thing as asymptomatic MISC-C. All of them have to have a fever. And then you can see GI symptoms are far more common in MISC-C than they are in acute COVID. And then a lot of these patients also have rash. Respiratory symptoms such as cough and rhinorrhea are much more common in COVID-19 or acute COVID-19 compared to a MISC-C. When you look at the lab markers, patients with MISC-C tend to have much more profound lymphopenia compared to those with COVID-19. And then again, looking at their LFT and ALT, ALT and AST, those with MISC-C tend to have sort of these borderline high liver function tests, whereas those with COVID-19 tend to have normal liver enzymes. And then a lot of these patients with MISC-C will also have renal dysfunction, and so they have these higher creatinines. All right. Again, looking at the inflammatory markers, MISC-C by definition is an inflammatory syndrome. And so patients will have profoundly higher levels of CRP and ferritin compared to those with COVID-19. And then because of this hypercoagulable state, patients will have higher D-dimers and fibrinogen compared to COVID-19 as well. When you look at the outcomes, a significant proportion, so about 70% of these patients, of the patients with MISC-C will require ICU level care, and compared to only about 3% of those with COVID-19. If you look at the length of hospitalizations, this is actually pretty interesting, and actually goes along with what I have noticed at my institution as well, is that patients who come with MISC-C, they're very sick, require ICU care, level care because of hemodynamic instability, but then we treat them with IVIG and steroids, which we will talk about in just a little bit, but then they get well pretty quickly as well. Whereas those with COVID-19, because again, in my experience, they tend to have more comorbidities and more respiratory symptoms, so they're in the hospital for a little bit longer time. Those with MISC-C, patients with MISC-C also tend to require mechanical ventilation more frequently because of the hemodynamic instability that they have. And death rate from MISC-C, again, the numbers are low in both syndromes or in both disease processes, but the death rate among children with MISC-C is about 20 times higher than that with COVID-19. So quickly, the differences between Kawasaki disease and MISC-C. So this is sort of, again, like as I mentioned, that initially there was a lot of overlap between Kawasaki and MISC-C because the definition of MISC-C was so broad that we think a lot of the patients who had Kawasaki's disease were also being diagnosed with MISC-C. And so this study, what they tried to do was classify all these studies that were out there as those that had classic MISC-C, so that met the definition, the CDC definition, those that were reporting acute COVID-19, and then those that were reporting Kawasaki's disease. And class 3 was basically the sort of very broad definition that probably included Kawasaki's as well. And so as I mentioned, the main difference between MISC-C and Kawasaki's disease is the age of the patient. A lot of these kids with MISC-C tend to be older, whereas the median age for Kawasaki's is about 1.6 years. A lot of these patients will have, those with MISC-C will tend to be will be antibody positive. So this is, and most of those with COVID-19 will be PCR positive and antibody negative. A lot of the MISC-C patients will have abdominal pain, which is very infrequent in Kawasaki's disease, and only about half of the COVID-19 patients will have them. These patients with MISC-C frequently present with shock. That's very rare in Kawasaki's disease. And a lot of the patients with acute COVID, not surprisingly, will have ARDS, and that's less common in MISC-C, and again, very, very rare in Kawasaki's disease. So just talking briefly about treatment of MISC-C, this is another a review that looked at 10 different studies, and they looked at the common treatment strategies that were used. These studies again sort of divided all the studies into 3 groups. They looked at those that were mostly sort of patients that had Kawasaki's disease, and then those patients where those studies that included that had to have patients had to have cardiovascular diseases in order to be classified as MISC-C, and then those were sort of had the broader CDC definition of MISC-C. So not surprisingly, studies that mostly included Kawasaki patients, those studies tended to use IVIG much more commonly than the other ones. But overall, IVIG was used very frequently if you look at all the studies together, and then followed by steroids and vasopressors. Again, a lot of these, the kids with MISC-C will present with hemodynamic instability requiring early vasopressor use, and then those that had MISC-C, a small percent of them also ended up on ECMO. All right, so this is a protocol that we use at my institution. We sort of look at our patients as severe MISC-C versus mild MISC-C, and those that are in the severe. So if you require ICU level care, you're obviously sort of in the severe category. If you're in the floor, if you're on the floor, then that's mild. And then we sort of look at the symptoms that we've talked about before. But coming to treatment, so we tend to start with Solumedrol at a pretty high dose. So we give about 10 milligrams per kilogram as a first dose. And then we also give IVIG at the same time, which is about 2 grams per kilogram. And then if there are some fluid issues, which because of the cardiac manifestations, patients we don't obviously want to overload them with fluid either. So in that case, we can start off with 1 gram per kilogram. And then if they're improving, then we reduce the Solumedrol to 2 milligrams per kilogram per day, and then for 5 days. And then as the CRP improves, we sort of manage. We taper the steroids as outpatient. And then if they're not improving, then we sort of think about either continuing that 10 milligram per kilogram Solumedrol for another 24 hours, or we'll talk about sort of using some of the biologics later on. We also almost always will put these kids on low dose aspirin unless they're on Lovenox or some for thrombosis. And then if there's some evidence of superinfection with bacteria, we use antibiotics, and we will use biologics if they are worsening. For mild disease, we tend to start off with Solumedrol 2 milligram per kilogram per day, and then sort of go from there. And if they're worsening, then we add IVIG on top of that. And we always follow these patients up. We always have an echo at the time of admission, 2 weeks after admission, and then cardiology usually does 6 weeks, a follow-up at echo at 6 weeks as well. And then if patients have severe MISC-C, which we've had, let's say about half of our patients do sort of fall into this category, and they're not improving on Solumedrol and IVIG, then we use anakinra or infliximab. Anakinra again is a IL-1 receptor blocker, or infliximab is the IL-1. It's a TNF alpha inhibitor, and so we sort of use those biologics as well in addition, and have had pretty good success in patients with MISC-C who have documented thrombosis or who have an ejection fraction less than 35%. They also receive an anticoagulation with enoxaparin at our institution, and they use that for at least 2 weeks after discharge. And indications for longer outpatient therapeutic enoxaparin include, if there's documented thrombosis, in which case they may be on it for more than 3 months, or there's ongoing moderate to severe left ventricular dysfunction. So in summary, MISC-C is is this post-COVID condition. Immune dysfunction is a hallmark of the syndrome. It can affect all ages. Unlike Kawasaki's disease, patients can get very sick very fast, and so it is very important to recognize this syndrome early in the ER. Cardiac dysfunction is very common. GI symptoms are very common and may actually mimic appendicitis. It's interesting. We've had at least 2 patients where they were admitted for appendicitis, and then once the surgeons, and they had appendicitis, once the surgeons removed the appendix, the patients still had very high levels of markers of inflammation, and then we sort of got a better history, and they had some exposure to COVID, and so we sort of think that this was actually MISC-C that may have triggered an appendicitis. And then IVIG and steroids are sort of the mainstay of therapy, and we use biologics if there is refractory MISC-C. So that is it. Thank you.
Thank you, Dr. Mehreen, for update on this still evolving important pediatric condition. I know it's late for you. We will start with questions. There are some questions for Dr. Nigat Mehdi. If you can, Mehreen and Faisal, if you